And I'll thank everybody for coming. Thank you so much. It's the first one of these we've done in a while, actually, so I'm kind of excited to get back into it. And tonight we have Dr. Richard Anderson with us. He's neurosurgeon out at NYU. And I usually start this off and you can launch into your presentation, but just maybe introduce yourself a little bit, talk a little bit about why you study and treat patients with Chiari, syngomyelia, this kind of, and CCI, I think we're going to get into a little bit today. Just kind of where that interest started, and then you can launch into your presentation.
Oh, perfect. All right. Thank you, Caitlin. And thank you, everyone, for joining us tonight. I appreciate the invitation from the Bobby Jones Foundation to give this presentation. As Caitlin mentioned, I'm a pediatric neurosurgeon. My disclaimer is that I only take care of children. I don't take care of adults. I don't like adults. Present company excluded, of course. So this presentation and my experience is really exclusively dealing with children. Chiari malformations and syringomyelia are one of the more common things that pediatric neurosurgeons deal with. And my real interest in it was because, I was at Columbia for over 20 years. I worked with Neil Feldstein, and we were one of the first teams and centers that really started doing research into treating Chiari with a non-dural opening, because we were monitoring these patients, impulses going up and down the brainstem during the surgery. And we're at the beginning, we were opening the dura like everyone else did. And we were noticing that the speed with which the impulses went through the brainstem was improving when you took off the bone. But then when you open the dura, it didn't improve anymore after that. So that kind of launched and piqued our interest into trying to understand the best way to care for children with Chiari-1 malformation. And then my personal interest really led from Chiari and into spine. And so because I take care of a lot of children with spinal disorders, issues with craniovertebral junction instability and spinal instrumentation, so forth, is something that really, you know, became a real clinical focus for me. So, with that in mind, I'll start going for this presentation. I'll put some slides together. That'll probably be about 20-25 minutes, just kind of going through how we think about. Instability in of the spine in situations of children with Chiari-1 malformations. And then there'll be plenty of time at the end. It's probably only be about 20-25 minutes. There'll be plenty of time at the end to ask questions, and so I can try to answer any questions that you guys may have. So the one of the things that comes up in treating patients with Chiari is the idea of, a very small percentage of these children can develop instability. But it's very hard to define that. And so it's something that we've talked about in our community, pediatric neurosurgical community, for a long time. And it's been, there have been some leaders in the field like Doug Brockmeyer who have really made some good progress into trying to understand that. But there's no real consensus among providers on how to identify it and take care of it. So I was approached by the Bobby Jones Foundation and other people to try to put together a group of experts to try to help define what instability is in these children, and to try to have some consensus or agreement among healthcare care providers, across the country and across the world, so that we could agree on definitions to try to launch clinical studies to get even better information. So the initial step on this is to try to just get a group of people who are experts in the field together um, to build consensus and get agreements. And that's what this first step is. And that's what we'll be talking about today, about building consensus toward a definition for instability in patients with Chiari malformation. And we did this through a modified Delphi study. So for those of you who are not familiar with the Delphi study was developed by the Rand Corporation back in the 1960s. And it really came out of the Cold War, when the government and industries contracted with the government were trying to figure out how many nuclear weapons the United States needed to build in order to try to protect the United States in the situation of some World War III situation. And nobody had any data real good quality data about what the Soviet Union had. And so they decided to put together a group of experts to try to come to consensus or try to figure out the best way to move forward. And so that's how the Delphi study really came about, or Delphi method. And so it's a method that solicits the opinions of experts through a series of carefully designed questionnaires, interspersed with information and opinion feedback in order to try to establish a convergence of opinion. So we have some experience with this in pediatric neurosurgery and pediatric spine surgery. We've done several Delphi studies to look at things like what are the best practices to minimize wound complications after tethered spinal cord surgery, or what are the best practices for traction for cervical spine patients, or how to reduce surgical site infection after scoliosis surgery, and so forth. So we have some experience doing this, and we have methods to try to be most effective in reaching consensus. So the purpose of this study was to build consensus for the definition of instability, how to define instability in the setting of Chiari malformation. And we started out by addressing this with both pediatric and adult patients. And the goals of the study were to try to better understand instability in the setting of Chiari-1 malformation, to better understand the indications to proceed with surgery or stabilization in the setting of Chiari-1 malformation and instability, and to help standardize inclusion criteria for children or adults that needed occipital cervical stabilization to help design clinical studies in the future. Importantly, we were not trying to determine the best surgical methods of treating patients with Chiari. So we were not trying to say, should the dura be opened, should the not dura be opened? Should this patient necessarily get fused, should this patient not get fused? It's not for individual patients. We're just trying to build consensus to how to define instability as a starting point to be able to develop clinical studies. So we started out with a very international, diverse group of participants that you see listed here. We had patients that, providers that take care of both or only children like me, children and adults like Doug Brockmeyer, people that took care of only adults like, Paolo and Petra. International group, Dominic Thompson is from the United Kingdom, Sandeep Chatterjee is from India. And so we had a very diverse group of attendees. And then we had some younger attendings, Nick Alexiadis and Raj Iyer, who are very interested in this research to help put everything together. So we started off in April 2023 with a kickoff hybrid meeting at the AANS, which was supported by the Bobby Jones Foundation. And that was a really important meeting because we had all these providers there. And after a series of questions and spending about 2 hours together, 2 or 3 hours, we came away from that meeting recognizing that pediatric and adult Chiari are very, very different. And it was very unlikely that we were going to be able to reach consensus on how to take care of these patients unless we separated out the adult population and the pediatric population. So we decided to do that, and there was universal agreement to do that. And so what this presentation tonight focuses on is the work we did to develop pediatric specific recommendations for children with Chiari and defining instability. So we did this work, which I'll go through with you, and we submitted it for publication, and then it recently got published, which I'll show you later. So as I mentioned, a disclaimer, and again, none of this is not focused on adult patients. It's really focused exclusively on pediatric patients, okay? So I want to start out with some background about pediatric Chiari-1 malformation. The vast majority of patients with Chiari-1 malformation are not complex. Almost all patients with symptomatic Chiari-1 malformation can be treated successfully with a standard posterior fossa decompression alone. Okay, these are symptomatic patients that need surgery, and if surgery is going to be necessary, the standard posterior fossa decompression works the vast majority of time. It's only in a very small percentage of these children that instability develops or instability is present that needs to be addressed. For instance, in a series, out of Alabama with 500 children that were treated for Chiari-1 malformation, only 4 patients required a reoperation because they had instability. So 4 patients out of 500, so less than 1%. And all 4 of these patients had severe, other base of the skull abnormalities like odontoretroflexion and ventral brainstem compression, which we're understanding now is plays a significant role in that. And when you look at other literature out of places like Utah and Iowa that quote very high rates of instability, it's very likely due to referral bias, where people are basically going from across the world and country to see these two providers because they've written a lot about, craniovertebral junction instability. It's not because that's a true incidence of the problem. This is it becomes even more clear when you look at databases like the Park-Reeves Syringomyelia Research Consortium, which I'm sure many of you know, is a collaboration with 40 children's hospitals from across the country entering database patients in this database. There are over 1,000 patients in the database now. But when we looked at this, initially several years ago, when you look at 640 patients that had surgery for Chiari and a syrinx, only 2.2% had fusions up front. Even smaller percentage of that needed ventral brainstem compression. So again, the whole point of this is just to really hit home the point that it's the very, very small percentage and very, very small fraction of patients with Chiari that are symptomatic that need treatment that actually have instability. So how do we classically define instability of the spine in any situation? The standard, what everyone goes to is the definition by Punjabi and White, who are kind of the godfathers of clinical biomechanics of the spine. And we define instability as the loss of the ability of the spine under physiologic loads to maintain relationship between the bones of the spine in a way that there's neither damage nor subsequent irritation to the spinal cord or the nerve roots. And in addition, there's no development of incapacity, deformity, or pain. So that's how clinicians think of instability. And if we think these things are happening, then it raises our suspicion that instability could be present. The problem with Chiari-1 malformation patients is that it can be very challenging to define instability. There's no clear consensus among neurosurgeons because there's no single radiographic or clinical finding that is present in all patients with craniovertebral junction instability. Okay, it's not like Chiari-1 malformation in itself. Chiari-1 malformation is a radiographic diagnosis. If the cerebellar tonsils on an MRI come down more than 5 millimeters, then by definition, by radiographic definition, it's a Chiari-1 malformation. Now, that doesn't mean that that patient will ever have symptoms. It doesn't mean that patient will ever need surgery. It's highly variable. But if the tonsils come down more than 5 millimeters, it's a Chiari-1 malformation. There is no study, blood test, there's no radiographic study, blood test, or anything on clinical exam that every patient with instability in this situation has. So that's why it's difficult to make the diagnosis. And the determinant is based on combination of clinical and radiographic findings. So if you look at clinical findings, we do have some guidance. So if you look at a series here of 500 patients that has no instability, and then you compare it to a clinical series of patients, a large series of patients that all had instability at the craniovertebral junction, we definitely see some differences. So if you look at hyperreflexia, upper extremity numbness and weakness, if you look at dysphagia or swallowing difficulty, decreased gag reflex, these are all much more common in patients that have craniovertebral instability as opposed to just standard Chiari-1 malformation patients. Well, what about radiographic findings? So Doug Brockmeyer has really done the best work on this in defining the kind of the complex Chiari malformation. And if you look at his papers and others that have been reproduced with the Park-Reeves Research, consortium, the combination of basilar invagination, Chiari 1.5 malformation, where the brainstem herniates down through the base of the skull, or a normal clival cervical angle of less than 125 degrees, these are all highly associated with children that have craniovertebral junction instability. And these patients in Brockmeyer's series were much more likely to go on to need stabilization for instability than patients that didn't have these findings. So when we think about instability as clinicians, there are different ways to categorize instability. And in Chiari patients, instability is almost always a chronic process. It's something that slowly develops over time. It's not like an acute process, like when someone has, trauma, like they're in a car accident and they have acute instability of the spine. It's not like that. It's a chronic thing that slowly happens over time. And we categorize it in terms of four different categories. There's translational instability. I'll go through each of these. Translational instability, a progressive deformity, neural compression, or incapacitating pain. And this goes back to that definition of instability, of preventing pain, deformity, neural compression. That's what instability is. And so these are different types of instability that can happen in patients with Chiari malformation. So if we look at the first one, which I call translational instability, that's literally where the spine is, when you're bending your neck forward and backwards, the spine is moving too far forward and backwards, at the craniovertebral junction. And the problem with that is because the spinal cord goes down through the center, then it can cause compression or damage to the spinal cord. So if you go back to Punjabi and White, at the base of the skull to the first level of the vertebral body of the spine, C1, you shouldn't have translation more than about 1 millimeter. And at C1, C2, you shouldn't have translation more than about 4 millimeters. So here's an example of a 16-year-old girl who presented with occipital headaches, posterior neck pain, arm paresthesias, classic symptoms for KR1 malformation. The pediatrician orders the MRI, shows a KR1 malformation, which I don't have on this slide, um, neurologically intact, but the patient had a congenital C1, C2 fusion, so a congenital bone anomaly on the MRI that prompted X-rays to be done prompted me to do X-rays to look for instability. And when this patient bends their neck forward and bends their neck back, if you look at this orange line as a reference line, then basically the spine is moving. This is the condyle, the front of the condyle, and you can see it's about 9 millimeters when this patient leans forward. But then when the patient leans back, the front of the condyle is right at this line. So it's the measurement from this line to the condyle is 0 here, and it's about 9 millimeters here. So this patient's moving 9 millimeters between the base of the skull and C1, which is much more. It shouldn't be moving more than 1 or 2 millimeters. So this child has occipital cervical instability. In addition to treating the Chiari, would need to be treated for instability as well. But this is a rare, and the reason for that, if you look at a CT scan, it shows that the joint here is very flat. Usually the condylar joint is like a cup and saucer, but it's very flat here. And so when you're moving forward, there's just nothing to prevent this from sliding back and forth. So that's what happens anatomically. But this type of instability in these children is very rare. And personally, in my experience in over 20 years, I've never seen translational instability in a KR1 malformation patient without having some other type of bony anomaly of the spine, like a C1, C2 fusion, or other genetic syndromes like Klippel-Feil syndrome or occipitalization of the atlas, or some other bony anomaly of the craniovertebral junction. So what's the much more common type of instability in these patients is what we call a progressive deformity. And this can be either with basilar invagination, which is where the skull literally sinks down vertically on top of the spine, or a progressive kyphosis, where the head bends forward on top of the spine. Um, and sometimes at least the progressive kyphosis can be iatrogenic. It can occur because of multiple operations from a posterior approach. And most of these are associated with ventral compression of the brainstem, like you see in this case here, where the dens is pressing ventrally on the brainstem. So here's a girl, I'll show you a couple examples, a 13-year-old girl who had Klippel-Feil syndrome and renal failure and osteopenia. So she has really weak bones, and the bone structure isn't very solid. So she had a Chiari diagnosis in 2015. This is her 2015 image, and you can see the Chiari-1 malformation where the cerebellar tonsils go down below the foramen magnum. But you see that the front of the brainstem looks fine. There's spinal fluid here in front, and there's no evidence of basilar invagination. The top of the dens here is below a line connecting, across the foramen magnum. But later, several years later, she developed central sleep apnea. She started to have to use CPAP or breathing apparatus to help her breathe. And She started to develop some developmental delays, but she was neurologically okay. But we repeated the MRI, and this is what a new MRI looked like. Look at how big of a difference here there is. See, now you can see that you don't see spinal fluid in front of the brainstem. You see that the angle here, which is the CXA, is almost 90 degrees here, whereas before it was like, 130 degrees. So you see that the head is just sinking down. The skull, the weight of the skull is just sinking down vertically, and the spine is just not strong enough to support it. So this is a child that we had to place in traction to literally lift the head back up off the spine and then decompress the Chiari, create more room here, and then do an occipital cervical fusion here to stabilize the position of the base of the skull with the spine so it wouldn't fall back down again. Here's another example, a little bit different situation of progressive kyphosis. This is a 12-year-old boy who had a Chiari with a syrinx, had a standard suboccipital decompression in 2015, and did very well with that, and the syrinx got smaller. But then the syrinx, he developed new symptoms about 4 years later. The syrinx came back, and I had to do a second operation again to decompress him. And he did well again for that for 3 or 4 years, but then he started to develop bad neck pain, hypernasal speech, and paresthesias, and repeated the MRI, and it showed a progressive kyphosis. So here was the initial MRI back in 2015, where you see the angle here as only about 137 degrees. And then you see now the MRI, and you see how this angle has fallen forward because he's kyphosed, or the head is just falling forward on top of the spine. And you see now that this angle is about 104 degrees. And this combined with the ventral compression is a good indicator that he was developing craniocervical instability. And so this is a child, again, that needed stabilization from the back. So the last category of the four was what we call incapacitating pain. And this is something that is much, much, much less common in the pediatric population. But this is something that I think does occur in the adult population. Um, this is the type of instability that's more associated with connective tissue disorders. And again, so it's much more popular in the adult population. And these are the patients that come in with chronic debilitating neck pain, but they don't, and they have a Chiari malformation, but they don't have translational instability on flexion extension like I showed you before. They don't have progressive deformity. They don't have ventral compression or basilar invagination. And the MRI doesn't show any neural compression, but they have relentless debilitating pain. They've through years of different therapies and with no relief. And if you put a collar on some of these patients, they can be significantly better. They can, with support of the head on top of the spine, they can have meaningful improvement in their pain. And the real question is how to identify these patients that would benefit from surgery. And the honest answer is that this answer is not going to be solved in the pediatric population because it so rarely occurs in the pediatric population. This is an answer that will only be answered by studying adult patients with Chiari in the adult population because it's much more common in that population. Um, I have done this once. So it can happen. Is a 12-year-old girl who presented with a Chiari, underwent standard decompression, her initial symptoms resolved, and about 5 years later, she just developed progressive incapacitating neck pain. There's no change in the CXA. There's no change in the compression. The CSF was wide open, but she was incapacitated. I put her in a hard collar, and 95% of her symptoms went away. And so, I had a discussion with the family. We ended up doing a fusion on her. She's done great, but this is very, very rare. And it's a very, very small percentage of patients that need something like this. So back to the study, this is the group of people that we put together to do this pediatric focused Delphi method. It's a great group of people, again, international group of patients or international group of providers. And all these providers were people that care for children either exclusively or predominantly. So the group is really robust. These were some intake questionnaires. Because it's with the Delphi method, the idea is to have a group of experts. Then we excluded any provider that's only been in practice for 5 years or less, and you can see that almost what we got almost over 80% of the patient or 80% of the people participating in this panel had between 16 or greater years of experience taking care of children with Chiari. Um, this group of providers, the majority of these providers, again, you know, almost everybody has done more than 100 Chiari decompressions in their career. In terms of occipital cervical fusions, this is much less common, as we discussed, but you know greater than most 50 greater than 50% of patients or participants have done between 11 and 25, and then a few participants that have done even more than that in very unique populations or settings. So we start out with an initial 61 question survey that was distributed regarding current practices. We did a second survey of 39 potential consensus statements. And then we had a hybrid meeting, both in person and virtual, to discuss some of these topics, to try to change the language to see how we could build consensus, to achieve as much consensus as we could. And we defined consensus as greater than or equal to 80% agreement on a 4-point Likert scale, where participants on a question would either strongly agree, disagree, or strongly disagree. So we were able to reach consensus on 22 statements. 8 of these had to do with risk factors and which children had a higher risk for instability and which children should be screened for instability. 3 consensus statements revolved around which imaging studies you should use to screen for instability. 7 consensus statements focused on radiographic measurements and clinical thresholds to determine abnormal motion, and then 4 involved therapeutic interventions to help determine abnormal motion. Now, this is a really good point. This is a really important point that I want to hit home, and that's why I put it in bold and italics. I've used the word instability throughout the entire talk here, and we started this process using the term instability. And during this process, we changed our language from instability to abnormal craniocervical motion for all these consensus statements. And the reason we did that is because across the country and across the globe, when you use the term instability in clinical medicine, then some doctors will use that as an excuse or justification to do fusion surgery. But this group's opinion is that the vast majority of these patients do not need fusion or stabilization surgery, and that more of that's being done across the country than is appropriate. And so we did not want to use the term instability in these statements because we didn't want to give anybody the platform to be able to use these statements to justify doing fusion surgery. So instead, we use the term abnormal craniocervical motion. Now, that's a more general, broad term because some children with abnormal craniocervical motion, it may be minor and they may not need stabilization surgery. Some children, like the ones I've shown you in the talk so far, have had very severe abnormal craniocervical motion and all would go on to require surgery. All right, so let me go with some of the results. This is the first part about risk factors and screening. As you can see from the results here, there was consensus that either asymptomatic or symptomatic patients with KIAR1 malformation, if they don't have an underlying bony anomalies or underlying genetic syndromes, they don't require routine screening for abnormal craniocervical motion because it's so rare. Again, the vast majority, 98, 99% of patients with KIAR1 malformation do not have abnormal craniocervical motion or instability and do not need to go through extensive additional workups like flexion extension MRIs, flexion extension CT scans, flexion extension x-rays to work them up for instability because the vast majority of them do not have it. There's a question raised about Chiari 1.5 as opposed to Chiari 1. So Chiari 1.5, again, is where the brain stem comes down a little bit farther. There have been some studies out there saying that, oh, well, if it's a Chiari 1.5, then they all have abnormal motion and they have instability. This group did not believe that. Again, it doesn't matter whether you have a QRI1 or a QRI1.5, regardless of if you're asymptomatic or symptomatic, unless you have underlying bony anomalies or an underlying genetic syndrome that puts you at much higher risk for instability, then you do not need routine screening for that. On the other hand, if you do have certain vertebral body anomalies like atlas assimilation, that's something where it was recommended to screen for abnormal craniocervical motion. If patients are symptomatic, if they've undergone prior surgery and have recurrent symptoms, then you need to worry about instability. And if you've got patients that have undergone surgery already, but their syrinx is getting larger or it hasn't improved, those are patients that you have to be more concerned about instability, and those are patients that there's consensus to recommend screening for their abnormal motion. If you've decided that you're going to do screening for abnormal motion, the one that's absolutely recommended is dynamic x-rays. So flexion extension x-rays, like I showed you in that example before, it's the gold standard. It's the only study we do where patients are standing up and gravity is in play. And the flexion extension, that's the gold standard. And it's the easiest because it's x-rays, it's virtually, it's minimal radiation exposure. And if you're not screening for ACCM, then dynamic imaging is not required. There was brought up among the group about whether upright dynamic imaging is required. Like, so when you're screening for this, do you have to do an upright CT scan? Do you have to do an upright, MRI? And this group felt that upright dynamic, so putting a child through an upright, flexion extension CT scan, upright flexion extension MRI is not necessary. You can obtain the information you need from those studies lying down if it's necessary. But again, the vast majority of patients don't need any of those studies. What about radiographic measurements? So when you've got studies, what measurements should you look at to help try to determine if there is abnormal motion? So there was agreement that you want to look for basilar invagination. You want to look at whether the DENS goes above that line across the base of the skull. You want to look at the PBC2, which is a measurement of ventral brain stem compression. You want to look at the CXA because all of these things have been identified in studies like Brockmeyer's and others to have a higher association with abnormal craniocervical motion. If the DENS goes above McRae's line, children should be considered to have basilar invagination. If children have bulbar symptoms like dysphagia or myelopathy, and imaging demonstrates a high PBC2 and a low CXA, these are the patients that are generally considered to have abnormal craniocervical motion. That's the most classic example, and these patients are at high risk for needing some type of stabilization procedure. In addition, if they have these symptoms, if they have translational motion more than 2 or 3 millimeters, they should be considered to have abnormal craniocervical motion and a high chance for needing stabilization surgery. Yeah, so it's like basically translate regardless of the symptoms, whether it's occipital headaches and standard symptoms or whether it's bulbar symptoms, these patients that have translational instability are high risk for needing stabilization surgery. So the last category was therapeutic interventions, and that's basically what should you do with these patients. And this, if you've got a patient who's symptomatic and imaging studies support abnormal cervical motion, so they have a low CXA, they have a high PBC2, they have basilar invagination. If they have imaging studies that support it, and you put a collar on them, and they have a meaningful improvement in their symptoms, that can be really helpful to diagnose abnormal craniocervical motion. But this is an important point. For children, if a child comes in with neck pain and you put them in a collar and their pain gets better, but they don't have any radiographic findings that are consistent with abnormal craniocervical motion, these are not children that need to be stabilized with surgery. And this group's feeling, and the reason this statement got 100% universal consensus, is because this group felt that in some places some children were getting surgery for stabilization in this situation that didn't have supporting imaging studies, and we wanted to try to move away and prevent that from happening. Um, on the other hand, children who have all these symptoms have supporting radiographic studies, put in a collar, and it really helps them and makes their symptoms better. Those are high risk for abnormal craniocervical motion and likely to require some type of stabilization surgery. If they fail a hard collar, then the group felt that it was not necessary to try them in a Minerva vest or a Halo vest or something like that, because they felt that that additional level of stabilization was not going to make a difference in the recommendation to move forward with any type of intervention surgery. So this is kind of a table to summarize what we felt was the most important parts of the finding. Again, that children that don't have underlying bony anomalies or genetic malformations, they don't require routine screening for abnormal motion. It is suggested for patients who have those type of bony anomalies or who have undergone surgery before and have recurrent symptoms or increasing syrinx. Um, the and then, the patients again that have bulbar symptoms and all these other findings radiographically and have supportive imaging findings of abnormal motion, those are children that you should really have a high suspicion for abnormal motion and consideration for some type of stabilization surgery. So this was, in case anybody wants to read into this further and read some of the questions that we had, this is the publication. It was Journal of Neurosurgery Pediatrics, published this year. So there's the reference if anybody has any interest in further reading. Thank you again to the Bobby Jones Foundation for this opportunity and for all of you that have joined. I'm happy to answer any questions that anybody might have.
Thank you, Dr. Anderson. That was awesome. There are a couple of questions that came in that were specifically pertinent to the presentation, so I want to get those out first. Um, First was, does this apply to atlantoaxial instability or strictly craniocervical instability?
It's a great question. We consider atlantoaxial instability as part of the craniovertebral junction. So if there's abnormal motion at either O to C1 or C1 to C2, that can play into this. So craniovertebral junction, abnormal motion encompasses both of those spinal levels.
Perfect. And then, are we talking strictly about Chiari-1, or would this also be implicated in patients with like Chiari-2 malformation?
So this really is focusing exclusively on Chiari-1 malformation. Chiari-2 malformation of myomeningeal is a very different situation. There are rare situations with multiple surgeries of decompressions where those children can also develop craniocervical instability, but it's a different situation, and we really haven't studied that population at all. But
And
it's a
then,
much rare. Yeah.
yeah, absolutely. And then you had mentioned it at the outset, and I guess just to clarify, adults and pediatric patients are very different. They had to be separated for this Delphi process. Can you explain what maybe some of those differences are to kind of help make it make sense a little bit?
Yeah, sure. So I think the biggest difference is that um, there's a much higher percentage of adult patients with Chiari-1 malformations that present with this chronic debilitating neck pain that have fewer of the classic Chiari-like symptoms that we associate with pediatric patients, like just occipital headaches and paresthesias and so forth. And I think that a lot of adult patients that have Chiari, there's a higher percentage of patients that have connective tissue disorders that are probably playing a role in this. And that last category of instability, this just incapacitating pain, neck pain, that doesn't have any of the other corroborating radiographic findings that we see in pediatrics. And so the pediatric providers are like, look, I don't see this in my practice. And I mean, I'm just not an expert in this type of problem because we don't see this in pediatrics. And so it made more sense to separate it because the whole point of a Delphi study is to have a group of experts making decisions. So you don't want somebody helping and joining in and making decisions when they're not an expert in that specific thing. So I think it really depended because everybody would agree on the translational instability. I think everybody agreed on the progressive kyphosis. Everyone agreed on the basilar invagination. It's just this last category where the pediatric providers are like, I don't know what you're talking about. Like, there's no way I'm going to fuse a child who comes in with neck pain that doesn't have any of these other radiographic findings. And I'm against anybody who's going to do that because I think that's wrong, you know? And so that's why we needed to separate the adult and pediatric providers.
Makes total sense. And then just as a caveat, how common would you see, you know, volumetric stuff? So like hydrocephalus, is that something you frequently see? And again, this is a small subset of the pediatric patients, but is that something that's common
Within
overlap?
So it's, I mean, the combination of Chiari-1 malformation and hydrocephalus is rare, but the hydrocephalus piece has not been shown to play into abnormal craniovertebral motion at all. So two
For sure.
totally separate issues. Yeah,
Absolutely. I'm going to get some of the questions that came in ahead.
sure.
So here it says, my daughter's had several surgeries for her Chiari. She has headaches 24/7. It's been about a year since the first surgery and 3 months since they went back in. So really the question is, why is she still having headaches? What's the possible pathophysiology there?
Yeah, so the difficulty with headaches is that if you look at big population studies, 95% of Americans have headaches at some point in their lives. And it can happen in children too, just like back pain. Lower back pain and headaches are the most common afflictions in Americans. The problem is that there's no study we can do to know with 100% certainty exactly what's causing the headache or where it's coming from. So, like we've learned, like I've seen thousands of patients that come to me with headaches and have an MRI showing a KR1 malformation. So as a clinician, I have to try to figure out, well, is that patient's headaches, is that child's headache coming from the Chiari or not? Because it's a really important distinction because if the headaches are not coming from the Chiari and I recommend surgery and put them through surgery, then their headaches aren't going to get better. And then everyone's going to be unhappy. And I'll put the child through the risk of surgery and she hasn't gotten any better. So that's why we are so, we try to be so careful to try to figure out what type of headaches are more likely to be related to Chiari-1 malformation, meaning what type of symptoms are make it more likely that that child is going to get better if we do surgery. And the classic symptoms are occipital headaches, headaches that exclusively occur at the back of the head, not headaches occurring globally, not headaches behind the eyes, not headaches at the temples, but headaches exclusively happening at the back of the head. Headaches that get worse with coughing, sneezing, bearing down, playing the trumpet, things like that. Pain radiating down the arms, numbness and tingling, clumsiness of the hands, swallowing, choking, gagging problems. These are the kind of symptoms that, from my experience and others, and in the literature, are more likely to improve if you do surgery to treat the Chiari. But a lot of families come and their children are miserable from headaches and they're incapacitated and they have a Chiari-1 malformation and their headache syndromes don't really fit with the Chiari, but they end up having surgery anyway because families are desperate. They just want their children to get better. I'm a parent. I have 4 children. I get it. The doctors are desperate because they want to try to do anything. They don't want to sit there and do nothing. They want to try to do something to help the child, but the child just doesn't get better. And what that means to me is that the headaches were not really generated from the Chiari-1 malformation, and they have some other type of headache syndrome. And if you think about headaches overall, I just mentioned that 95% of Americans have headaches. So think about how many hundreds of millions of people have headaches. How many of those are treated with surgery? How many of those have Chiari? It is the fraction of 1% of those patients with headaches overall that get treated, that have a Chiari, that get treated with surgery. So the vast majority of headaches out there are not caused by Chiari-1 malformation. So when you have a child with a Chiari-1 and headaches, the real skill and art is to try to figure out which children are going to benefit from surgery and which ones aren't. And so, in this situation that you've discussed, I think it's likely that there's some other component that's causing the headaches, and maybe the Chiari caused some of the headaches, and maybe some of her headaches were better after surgery, but some of the other headaches or a different type of headache is going to be best managed medically because that's the vast majority of headaches are treated with medicines, not with surgery.
Yeah. To that point a little bit to dig in, specifically for I guess younger patients because they don't always have the vocabulary. How do you typically counsel parents, I guess, to like ask their child, all right, well, where does it hurt? What hurts? Like, how do you teach the
Yeah,
parents to do that?
yeah, no, that's a great point. And so children who are, younger than, 3 years old and who, where it's difficult to communicate exactly where they're having discomfort, then, a lot of times you're looking for different things, right? And, in that situation, you're looking more for swallowing problems. You're doing surgery more for progressive syrinx, because, high level children who are, high level performers in school and sports and stuff like that, those are the ones where headaches are going to be debilitating them and stopping them from doing the things that they want to do, right? But a 3-year-old is rarely going to be debilitated just from headaches, right? Like a Chiari type of headache, because 3-year-old isn't doing the same high level stuff that, a teenager in AP classes is doing. So you're looking for a little bit different stuff. Um, and there's just no way you're going to operate on a 3-year-old child, if, for, oh, well, occasionally my child holds the back of their head, or, like, my child's speech isn't great. My child has a speech delay and they have a Chiari, could this be causing it? And there's no way you're going to operate on that because speech delays are so common, and there's been no association between speech delay and Chiari-1 malformation. So,
Okay.
in younger children, it's a little bit, but usually those children you wait, to see if something really develops or not.
Sure. Um, this is a good question that we always get. So, really, it boils down to how do you know if the child has Chiari? So, this patient, I have an unremarkable MRI, but all the symptoms for Chiari online seem to match perfectly. So, how do you know when it's time to see a neurosurgeon versus, trying to manage those symptoms via some other specialist? How do you know if it's Chiari?
So, yeah, so Chiari-1, and we touched this, based on this a little bit earlier. Chiari-1 is a radiographic diagnosis. So, if the cerebellar tonsils do not come down more than 5 millimeters, it is not a Chiari-1 malformation. Chiari is a radiographic diagnosis. So the real question you're getting at is like, well, so if my child has a lot of symptoms like headaches at the back of their head, they have numbness and tingling and so forth, but their MRI is totally normal, would they benefit from some type of surgical intervention that a neurosurgeon could provide? And the answer to that is very unlikely. It's very unlikely because the whole point of a Chiari is that there's not enough room. The reason symptoms are developing is because there's pressure. And what a neurosurgeon can do is relieve pressure on the brainstem or the spinal cord. Okay, that's what we do in surgery. We relieve pressure. We allow spinal fluid to circulate. So if there's pressure that you see on an MRI, if there's pressure causing obstruction of spinal fluid flow, causing a syrinx in the center of the spinal cord, causing expansion, that's something that we can address as neurosurgeon. But even if a child had, or even if an adult had all the same symptoms as you read on a Chiari-1 malformation, those common symptoms, if the MRI does not show compression, if I took you to the operating room, I wouldn't know where to make an incision because there's no compression. So what am I doing there? There has to be compression. And what that means, which is a really good point that you're getting at, is that the symptoms that are most commonly caused by a Chiari can also be caused by other things. Okay. And usually that's when you need the help of a good neurologist who specializes in headache management. Sometimes we need pain management doctors that specialize in medical management of pain, to help allow children and patients to live their best lives, um, but without needing surgery. Because without compression on an MRI, without a syrinx developing, there's no role for surgery.
Yeah. Um, Sort of in that vein, this question is there any way to know if a doctor is a quote unquote expert? This is specifically to syringomyelia. I live a few hours away from the closest major hospital, and even though we probably can't afford to make the trip, I'm afraid to just let anyone do surgery on my 11-year-old. What am I supposed to do?
Oh, for sure. Yeah, no, it's never an easy decision as a parent to let anyone operate on your child. The honest answer is that um, every pediatric, in order to be a pediatric neurosurgeon, all I'd recommend is if it's an 11-year-old child, you want your child operated on by a pediatric neurosurgeon. You don't want to go to an adult neurosurgeon that occasionally takes care of children. And the reason for that is because the tissues are different, they're more fragile than children. You want someone who all they do all the time is take care of children, and you and um, almost always a pediatric neurosurgeon is going to have more experience than an adult neurosurgeon, except for a handful of rare exceptions across the world. A pediatric neurosurgeon is going to have more experience than any adult neurosurgeon in Chiari-1 malformation or syringomyelia. So if you're able to be in an area where you can see a dedicated pediatric neurosurgeon, you're already way ahead of the game. And as long as you have a relationship with that doctor and you trust that doctor, then you're going to be in good hands.
Right. And to the point of the pediatric specialist, so there's an interesting question, and we've gotten this once or twice before. Is it better to have surgery, and this is Chiari, before or after puberty? Is there anything, and this is particular to girls, is there anything about puberty that might make the outcomes of surgery better or worse or more difficult or?
It's an interesting question. There's no literature. No one's ever done a study comparing, basically taking 100 children that had Chiari symptoms, that have a Chiari, that everyone agrees needs surgery, that were right before puberty, and then divide them in two groups, operate on the first 50 of them before puberty, and delay and operate on the second group of them, 2 years later, after they've gone through most people. No one's ever done a study like that, and no one ever will. A study like that will never be done because if someone's you don't need surgery unless they're symptomatic and really symptomatic. Because if they only have mild symptoms, you don't do surgery, right? You only do surgery when someone's really debilitated or they have a progressive expansile syrinx, and then you're not going to wait for 2 years for them to undergo puberty and their symptoms get worse and then be miserable for another 2 years. You're going to want to intervene to help them as soon as possible. But there's nothing pathophysiologically that would make me think that, and from my experience and experience of others, and there's nothing in literature that would suggest that Chiari outcomes would differ before or after surgery. I mean, before or after puberty.
Mhm. Um, this is a bit of a rough question, but what does someone do if they disagree with what a previous physician has documented in their medical record? Is there something that they can do to change it? This happens more frequently, I guess, in adults, but I'm sure it happens in peds as well.
Um, it's a good question. I don't know the mechanisms of how to like approach a hospital to have them change a medical record, but I'm sure it can be done because errors can be made. And so if it's a medical error, it's different if it's an opinion of one doctor versus an opinion of another. But if there's something in the medical record that says that, my child had a hernia repair surgery in 2010 and they never had hernia surgery, that's a clear medical error. And there are mechanisms by which to go, to approach the hospital, speak with the medical records people, and to get them to extract that from the chart somehow, or document that that was an error moving forward so it doesn't get carried on. If it's a difference of opinion of two different doctors, having different opinions, then that's not, a medical error, and that's just differing opinion. And if families ever see a doctor that they don't agree with their opinion on how to do something or what to do, or even their diagnosis, that's 100% okay. But the best thing to do in that situation is just get another opinion. Go to a different doctor, get another opinion, so you have additional documentation that says, okay, well, I disagree. One doctor says you need surgery, and then you're like, I don't think that's true for these reasons. You go see another doctor. Okay, I don't think this child needs surgery. So getting another opinion is often the best way to do that.
There's actually this is the perfect segue. The first surgeon we saw for our daughter, she did not think she needed surgery, but to be safe, we got a second opinion. The doctor said that they would do surgery. So what are they supposed to do next?
Yeah. So you know, I always tell people they can always go see a third opinion for the tiebreaker, okay? But in general, if someone's recommending surgery and someone's not recommending surgery, you can never take surgery back, right? So typically in that situation, I lean towards not doing surgery. And if symptoms progress, because if symptoms are really bad, then it either means that if symptoms are really bad, it means that if surgery was not recommended by someone, it means that person doesn't think that your child's going to get better with that surgery. And in that situation, I think it's really dangerous to go through with surgery because the chances are much higher that your child's not going to get better and everyone's going to be unhappy. And in that situation, because Chiari surgery is never an emergency. It's never emergencies are when I meet you and I got to operate on you that night or the next day. Those are emergencies. Okay. And unfortunately, in our line of work as neurosurgeons, we have to deal with that not infrequently. But Chiari surgery is never an emergency, which means you have the time to go get another opinion. You have the time to drive if you need to see another doctor, to get on their schedule and get that third opinion if you need to. But in general, I always recommend to lean towards not doing surgery until something changes where that other doctor again, now something's changed and you do need surgery and there's agreement, or you have time to get that third opinion that, helps the tiebreaker.
I want to get to a couple of questions about the surgery itself. And um, how do you usually make a plan for surgery? So do you typically do the same thing with all patients, or do your techniques change based on symptoms or stuff like that?
So that's a great question. That's a great question because if you talk to 10 pediatric neurosurgeons, they're going to tell you 10 different ways to do the surgery. And this is one of the things that we're working hard to try to delineate. The problem is that there are a lot of people out there that feel there's only one right way to do the surgery. And I've always championed and believed that the discussion should not be what is the best way to do the surgery for all patients. The research should be what is the best surgery to do for each specific patient. Okay. So I mentioned that we did a lot of work, my partner and I did a lot of work on non-dural openings, and we showed with over 160 patients that if you don't open the dura, over 91% of children got better. And the huge advantage of a non-dural opening is that the chances of a meaningful complication are as close to zero as they can be. But it doesn't work for 100% of patients. So we tried to figure out which patients doesn't it work for. And what we found in our study is that if the tonsils went down below C2 and you had to take off part of C2, then the success rate for that operation went from 91% to about 60%. Okay. So, but it didn't matter whether you had a syrinx, didn't matter whether you're a boy or girl, it didn't matter whether you're 3 years old or 15 years old. None of those had any influence on whether not opening the dura worked or not. So, so we're still learning. And I have specific indications. I'm a big believer in non-dural opening, but there are situations in which I will not offer a non-dural opening, and I insist on opening the dura. And in my practice and my belief, based on literature and my experience, those are situations where the tonsils go down, below C2. If someone has a rapid neurological decline with a huge syrinx, meaning like they were fine a month ago and now they can't lift their arm because they have a huge syrinx. And the reason for that is we've done studies that show that when you do a non-dural opening, it takes a longer time period for the syrinx to get smaller than if you open the dura. And I want that neurologic deficit to go away as fast as possible, which means I need that syrinx to go away as fast as possible. But so that's also, if somebody has a rapidly progressive scoliosis with a syrinx and their scoliosis is greater than about 35 or 40 degrees, because once a scoliosis curve becomes more than about 45 or 50 degrees, then the horse is out of the barn, and no matter what you do, they're going to end up needing scoliosis surgery. So again, if they have a huge syrinx, I need to decrease that syrinx as fast as possible to maximize the chances that that scoliosis will stabilize or improve. And the last indication for me in my practice is if someone needs an OC fusion, because if they need a stabilization OC fusion, I need to do absolutely everything in my possible to maximize the chance that's going to work. Because if they're in the 9% where non-dural opening doesn't work, and I've done a fusion, then I need to go back and drill out a fusion mass, take out screws and rods to then do a dural opening, which would be a much bigger operation. So it's kind of a long-winded answer of saying that, in my opinion and in my practice, you absolutely do need to tailor the surgery for the patient, but it's not like there are 100 different techniques to use. There are basically 2 or 3 different operations that you do depending on the needs of the child.
Mhm. So you touched on scoliosis, so I'm going to do this question. For patients who have both tethered cord and scoliosis, do you typically do a surgery first, or is it safe to do both at the same time? Is that too much at once, or
Do you mean tethered cord and scoliosis, or tethered cord and Chiari-1 malformation?
this is scoliosis?
Scoliosis. So if they have tethered cord and scoliosis.
Yeah, sorry,
So
shifting gears a bit.
no, that's a good. No, it's a good question. So we have done research on this through the Pediatric Spine Foundation, which is the largest spine registry in the world, international registry. Um, Typically, so it depends a little bit on the degree of scoliosis. So if someone already has a 60-degree scoliosis and then they have a tethered spinal cord, if it's a simple phylum, like it's a simple tethered spinal cord, then studies have shown that the complication rate is the same if you do it at the same time. It's okay, because that patient also needs scoliosis surgery. But if it's a young patient and the curve is less, I guess what I'm trying to get at is what you really want to do is you want to get an MRI in those children who present with scoliosis as early as possible, because there are data that show that the earlier you intervene on a child with scoliosis and a tethered spinal cord, the earlier you detether them or treat the tethered spinal cord, the higher the likelihood is that their scoliosis will stabilize or not progress.
Thanks for
Okay.
jumping off without.
Yeah. Sorry.
Yeah,
Yeah.
sorry, had to derail you a second.
No.
Um, this one came in ahead too. So, how much does a high Beighton score impact the probability that decompression is going to result in craniocervical instability? I know you touched on it, but especially for the Chiari 1.5, the syrinx, and I imagine it's different in adults and peds, but
Yeah, it's a great question, and and honestly, I'm not the best person to answer that question, because, as many of you know, the Biden score is a scale to measure, kind of joint hypermobility, and it's something that, is done with connective tissue disorders, and the relationship between that and abnormal craniocervical motion and the need for stabilization, it's just it's so much more common in the adult population. We just don't see it in pediatric population, except for extraordinarily rare circumstances. So I'm just not the best person to answer that question. And, we need to get one of the adult guys, to do a session like this on, who is Dr. Ravinda leading the charge for the Delphi with the adult population?
yes, yes,
Okay,
yes.
perfect.
I
So
actually,
he'll
this is a
be,
good reminder. I have to bug him.
yeah, it'd be a great person to do a similar type of, presentation once they complete this similar Delphi study on the adult side.
Mhm. A question in the chat is it rare for odontoid resections to be done in peds?
Yeah, remember, of all pediatric
Yeah.
Chiari-1 malformation, we're talking about, less than 1%. So yes, it's very rare. When we do ventral decompression or odontoid resection, when we talk about ventral decompression, it means that the odontoid is retroflexed and it's pressing into the brainstem. And when we do that, typically we do transnasal. Now we go through the nose to decompress that, and it's a very effective surgery. But fortunately, it does not need to be done in most and it's very rare to need to be done. But when it's done, it's usually very successful.
Um, just like post-operatively, how long after surgery do you get MRIs? And is it this question is it something my child will need to do for the rest of their life?
Absolutely not. Okay, absolutely not. So typically we get, any child with a KR1 malformation needs an MRI of the entire spine because we're looking for a syrinx because again, the natural history of a KRI1 malformation without a syrinx is highly variable. The vast majority of children that I see with KRI1 malformations do not have symptoms, do not need surgery, are never going to develop symptoms their whole life. Um, if a child has a KRI with a syrinx that's expanding and growing over time, that's a different situation because the natural history of a Chiari with a syrinx is that the syrinx is going to get larger over time, ultimately cause neurological dysfunction and compression. So that's why children who have a Chiari with a syrinx, we recommend surgery for, even if they're asymptomatic, because the natural history of that is to cause problems and we don't want problems to develop. So if a child a child comes with a Chiari, they always need an MRI with a syrinx. If they do not have a syrinx, I follow them clinically in the office once a year because a small percent of those patients can develop symptoms. It's probably only about 5%. And the real value of that is to do a little bit of a neurologic exam and to remind parents and children the signs or symptoms that I'm concerned about that would make me want them to call me and be like, oh, we need to see Dr. Anderson because this may be Chiari related. Okay. But they don't get any more MRIs because if a child were to develop a syrinx 5, 10 years, 20 years down the road, then I would expect them to develop symptoms consistent with a syrinx, develop progressive back pain, neurologic dysfunction, or something like that. And the new symptoms would prompt an MRI to be done that would show a syrinx, and then that would cause treatment. If a child has a syrinx and they have surgery, then typically I wait a year after the surgery to do another MRI. There's a lot of equipoise. Some people do it 3 months if they do a dural opening. What the studies show is that if you do a dural opening, it takes about 9 months for the syrinx to reach its maximal state of decompression. If you do a non-dural opening, it takes a little bit longer than that. It might take about a year or so. That's why I wait if I do a non-dural opening. I just do everybody at a year. Unless there's a clinical problem. If there's a clinical problem, if children don't get better, if something's getting worse, we get an MRI anytime. But if children are doing great and beautiful and their, symptoms are much better or resolved, then I image them at 1 year. If that MRI looks good, no more MRIs. There's absolutely no need to put your child under general anesthesia every year for the next however many years, or the emotional turmoil of, of getting an MRI and wanting it's just not necessary because you're going to follow them clinically.
To that point, there are two more questions um, about
Can
tracking
and then
this.
well, I'm sorry, I'm gonna have to step off, so we can answer those
Okay.
questions, and then I'm gonna have to step off after that.
No, yeah,
But,
absolutely. You know
okay,
what? We'll just do the one and then the next one is very, very basic. So
okay.
it's exactly to this. So do you have any suggestions about how to track symptoms after decompression? So the parents notice that the symptoms will come back. How long do you watch for them and what are you looking for?
Yeah, I mean, we're parents, right? We watch our children their whole lives, but typically, if you're in that rare situation where, symptoms get better after a Chiari, but then scar tissue forms on the inside after a dural opening or something like that, and Chiari symptoms come back. It's all the same symptoms you're looking for. So basically, when you follow people clinically afterwards, you're looking for all the same Chiari symptoms. You're looking for a recurrence of occipital headache, headaches at the back of the head, worsened with coughing, sneezing, new swallowing, choking, gagging problems, hypernasal speech, pain radiating down, numbness and tingling radiating down the arms, weakness, clumsiness in the hands, tingling in the fingertips. These are all, you're looking for all the same symptoms that you were looking for to diagnose the Chiari and decisions that you would consider to determine whether treatment's necessary or not.
Perfect. Next one's a softball. How can people get in touch with you if they want to do that?
Oh, just you call my office anytime, and I'm up. If you just search me on the internet, it'll all come up. You'll see me. I got my phone number there. You can email me anytime. Any way I can be helpful in any way, I'm happy to.
Perfect.
Okay.
Thank you so
And for
much,
people
Dr.
who live far
Anderson.
away, we do, telemedicine all the time.
Yeah.
It's really changed, so it's a lot easier now. So,
Yeah. Thank God.
okay.
Thank you so much, Dr.
Of
Anderson. Thanks everyone for
course.
joining.
You betcha. Okay.
Have a good
Bye-bye
night.
now.